Good afternoon. Today I'm going to discuss with you the differential diagnosis of allograft dysfunction, concentrating mainly on acute allograft dysfunction. But I'm going to present some slides about chronic allograft dysfunction. So I'm going to cover these topics with some slides for introduction, followed by, because the diagnosis of allograft dysfunction depends upon lab, radiology, and pathology. So radiology is one of the corners of the diagnosis, and I am going to demonstrate how to use them for the help in differential diagnosis, and then delay graft function, use of biomarkers to diagnose allograft dysfunctions or rejection, some cases, our experience, and I'll end with guidelines. Let us start with the acute complications after kidney transplantation. This is the type of complication, as you see: acute rejection, tubular necrosis, artery stenosis, artery thrombosis, renal vein thrombosis, urinary tract obstruction, leak, urinoma, hematoma, abscess, and lymphocele. And you can see the incidence percentage for each of the complications. The clear message and the key message of this slide, I want to say that acute renal allograft dysfunction is not exclusively restricted to acute rejection. So we can find many issues explaining acute allograft dysfunction, and to be put in our mind when we are facing a patient with acute allograft dysfunction, to think of all these etiologies. And this slide summarizes the timing of the complications. If we are here in the first part, in the first period after transplantation, we may think of this cocktail of side effects: acute necrosis, rejection, thrombosis, infarction. Usually the vascular catastrophe occurs very early. And then if we are a little bit late, we can think of BK virus nephropathy, and the artery stenosis, PTLD, post-transplant lymphoproliferative disorders, stones, drug toxicity, and here one of the most important and famous drugs that can cause allograft dysfunction is calcineurin inhibitor, either cyclosporin or tacrolimus. And chronic allograft nephropathy, or chronic, as recently represented in the PAMF 2017, we may find chronic antibody-mediated rejection, or even chronic active T-cell mediated rejection. So a lot of causes, as you see, and the majority of this slide are representing acute allograft dysfunction, and here you can find some cases of chronic allograft dysfunction. And this is another data explaining the early failure of kidney transplant. If you look here, we have for the early, especially in the first hours after transplantation, you may find the causes of acute graft loss, representing the vascular catastrophes like venous thrombosis, and these are other causes: primary non-functional graft, acute rejection, arterial thrombosis, recurrent primary disease, or thrombotic microangiopathy. So always we should think of differential diagnosis, and not to be narrow-minded, thinking of only one diagnosis, which is rejection. This is an example of, can you diagnose this case? If this is a patient presents after a period of transplantation, and the patient presents with proteinuria and rise of creatinine, what's your diagnosis, Muhammad?
The first slide is silver stain.
Yes, it is silver stain, and this is the Mason.
The Mason trichome.
I think sclerosis, segmental sclerosis is quite obvious, and so this is a collapsing variety of FSGS. This is one of the most famous recurring disease, and this slide summarizes the glomerulopathies that can recur after kidney transplantation. So IgA, this is the risk of recurrence, 50 to 60% histological recurrence, but clinically from 7 to 30, and this is the percentage of graft failure due to recurrence. FSGS, 20 to 40%, and here this leads to 20 to 27% graft loss. Membranous, MPGN, Nowadays, we don't like MPGN type 1 and type 2, but we like immune complex mediated or T3 glomerulopathy, ANCA, associated glomerulonephritis, systemic lupus erythematosus, and GBM and fibrillary. So if you fix this slide, you can know the risk of recurrence and the risk of graft failure 5 to 10 years of the patients. So another study showing the recurrent glomerulopathy, although it is assuring because the percentage of recurrence is not so high, but the most important message is after recurrence, here you can find the recurrence is responsible about 50% of graft loss. So still recurrence is bad news in transplantation because it is associated with graft loss. Regarding the use of radiology in transplantation and in explaining allograft function, here we have, these are the different modalities of radiology: ultrasound, computed tomogram, MRI, this is nuclear renogram, digital subtraction angiography. And these are the complications for early post-operative graft dysfunction. Here, ultrasound is considered the first line. So the clear message, whenever you find rise of creatinine or proteinuria and you are diagnosed with allograft function, the first step is ultrasound for all cases. Why ultrasound? Because it is very cheap and it can give us a lot of information about the allograft. And especially if you find hydronephrosis, you should think of graft obstruction. And if the ultrasound is augmented with Doppler study, you can have a lot of data from, as I'll mention later within this presentation. So the first line for early post-operative dysfunction is ultrasound. And here you can find renogram is second line. I'm not believing in renogram. So I'm not advocating the renogram to be frequently used in transplantation. Obstruction, again, the first line is ultrasound. And the second line is CT scan, if we are thinking of the cause like stone, because CT scan without contrast is the best. Yes, and you can consider it as the gold standard for diagnosis of stones. For renal artery stenosis, we should start with the ultrasound. Then we can think of the MRI or CT scan or the digital subtraction angiography. So we start with the ultrasound for up to this moment. For fluid collection, needless to say, ultrasound is very crucial because it gives us an idea about the presence or absence of collection. And then we can go to the second line or third line to solve the problem. For BTLD, ultrasound is not superior, but the superior is MRI. And CT scan, PET scan, and MRI, both of them are the first line for diagnosis BTLD. For nephrolithiasis, the first line is CT scan because it picks up stones. For biopsy complications, if the patient after biopsy presents with complication, the first test to be used is ultrasound. So these are the modalities, and this is the complications, and I mentioned how to think of the use. Regarding ultrasound, there are many advances in radiology. One of the advances in ultrasound is adopting three-dimensional ultrasound of the graft. If you look here clearly, you can find the stenosis. It's very clear by three-dimensional. So three-dimensional may be the second wave in ultrasound, in the evolution of ultrasound. I fix this case. If this is a case who presents with post-transplant graft dysfunction, what's your diagnosis, Muhammad?
I can see that there is hydrouretary nephrosis.
Yes, perfect. So if we find this is the black color denoting the obstruction, because this is the dilated ureter, pelvis, and the calyces system. So this is obstructed kidney. And I remembered one of very interesting cases. We have a case, there was immediate diuresis, a lot of urine coming, and then after a few hours, when the patient was transferred to the intensive care, we found a complete anuria. If we are confronted with complete anuria immediate after transplantation, the first possibility is the graft earth thrombosis. It's vascular catastrophe. But when we do Doppler, when we did Doppler for this case, we found the graft was perfectly perfused, so we are assured. But we found immediate hydronephrosis. So what is the diagnosis if we have immediate hydronephrosis after kidney transplantation?
The ureter might be kinked. It needs to be.
So we think that there is a problem, surgical problem, and the patient was immediately explored, and the result was obstruction by tunnel hematoma. As you know, the ureter is inserted within a tunnel, so the tunnel was there was a hematoma that obstructed the ureter, and this was behind this. After removal this hematoma, everything was very nice, and the uresis was perfect again. So we should, and this was a funny case that we encountered in our series. But whenever you find obstruction, you should deal with obstruction by drainage, and then think of the cause of obstruction. Is it stone, stricture, or whatever the cause of, or collection, compressing ureter? So this will be the second step. The first step is to release obstruction, and the second step is to think of the definitive treatment of the obstruction. This is regarding the renogram. As I mentioned within this presentation, I don't believe so much in renogram, and its use currently is very limited after the availability of Doppler study. And here this is the common scintigraphic findings and onset of complications. This is renal artery thrombosis in the first week. Here you can find absence of perfusion and function. So in renal vein thrombosis, absence of perfusion and function. In hematoma, photopenic area, seroma, same, urinoma, you can find the leakage outside the kidney and the collecting system. So as you see, for each complication, there is a scintigraphic finding. But as I mentioned, I don't believe so much in renogram. And I think its value is just to confirm the presence of obstruction whenever it is query. Regarding MRI, a lot of innovation in the MRI, and this is one of the interesting reviews showing innovative perspectives, gadolinium-free. So here, no use of gadolinium. And the MRI for the graft can help us to know everything. Oxygenation by using bold imaging. This is a special technique, blood oxygen level dependent imaging. Water diffusion and the tubular flow by using diffusion weighted imaging. Diffusion tensor imaging, and I'm going to show you in a minute one of the photos for diffusion tensor imaging. Arterial supply by arterial spin labeling. Scarring by these techniques. Inflammation, vascular activity, even we can follow sodium reabsorption. So a lot of innovation can be known from the MRI technology. This is diffusion tensor imaging showing a very fantastic view of the graft. Let us go to another case. This is a case with progressive renal dysfunction after the graft biopsy. What's your diagnosis?
We can see that there is patchy perfusion, absent diastole all over the graft.
Where is there is no power Doppler here, just a pulse Doppler, and here this is a big hematoma. So the gray scale shows big hematoma. So after kidney biopsy, you may find big hematoma. Big hematoma compresses renal parenchyma, leading to what is known since a long time, beige kidney, increasing intravascular resistance. And here, the best treatment is to remove to drain the hematoma. In native kidney, if we diagnose beige kidney, we even may give angiotensin converting enzyme inhibitors. But I prefer here to deal with hematoma. To remove the hematoma, everything will be corrected. And this is another case of hematoma. You can find here the hematoma. And after releasing of the hematoma, the graft functions improved significantly. This is another case of hematoma. This is a very interesting case. This is a case with the diagnosis of acute allograft failure, nearly a decade, 10 years post-transplantation. And this was a case of diabetic nephropathy and with peripheral vascular disease. And this is the presentation. What is your impression? Here, if we should respect the history. We should take detailed history, because when they considered peripheral vascular disease, here you can reach the diagnosis. The graft vessels are very nice, but the problem is in the vessels. So this native common iliac stenosis and atheroma. So this was related to the native vascular disorders. And after doing angioplasty for this, the graft function improved. For delayed graft function, we are happy in live donor kidney transplantation because the incidence of delayed graft function is very low. Because the best definition of delayed graft function is the need for dialysis in the first week after transplantation. And this is very interesting and very important in cadaveric renal transplantation. And the causes are either related to the donor, like these factors, recipient-related factors, preservative factors, or transplant-related factors like these factors. So, and if you go to the Google and you just write delayed graft function risk calculator, you will find this calculator. Just to fill in the space. And if you fill in the space like these points, you will find here in the calculator the risk of occurrence of delayed graft function. If the patient has these characteristics, it's 52%. So it's a very nice calculator. Let us to shift to the living donor kidney transplantation. Is it necessary to do dialysis within the first 24 hours of transplantation to avoid delayed graft function?
No, it's not.
It's not. So when should we do dialysis?
At 2 days before the operation.
No, the indication of dialysis, it is better not to stress on doing dialysis within 24 hours, except if there is urgent need like hyperkalemia, acidosis, etc. And this is the contrary to the other surgeries, other operations, because in renal transplantation, we like the patients to not to be dehydrated, because this will help in immediate diuresis. So it's better to do the regular dialysis, not necessarily to do dialysis in the immediate day before transplantation, except if there is necessity. And as you see here, dialysis within 24 hours of transplantation doesn't improve graft function. Is there a difference between the outcome of graft if the patient was dialyzed through hemodialysis system or peritoneal dialysis system?
Yes, there's difference.
What's your expectation?
I think that the outcome would be better with those who were.
So you are expecting delayed graft function more with hemodialysis or with peritoneal dialysis?
Peritoneal.
So here your answer is not right. Delayed graft function occurs frequently if the patient is coming from hemodialysis. Okay? Because peritoneal dialysis is more physiological, as you know. Regarding the protocol biopsy, and this is one of the important points that I'm stressing upon how to improve the outcome of transplantation, is by adopting the policy of surveillance or protocol biopsy in general. In delayed graft functions, I think we should adopt this policy. Why? Because if we are waiting the graft to work, to have a function, and there is superimposition of rejection or any pathology, and we omit and neglect to treat this pathology, this will be catastrophic. So if the patient graft doesn't work, it's better to check the histology according to the protocol to diagnose superimposed rejection. If we have superimposed rejection, we should treat rejection to allow the graft to function. And here you can find if there is rejection, delayed graft function plus T-cell mediated rejection, the outcome is adversely affected. Regarding the biomarkers, do you encourage the use of biomarkers in transplantation for helping the differential diagnosis of allograft dysfunction?
I do. Because it will make the survey easier and it will make us avoid.
Which biomarkers do you recommend? Still, the gold standard for diagnosis of allograft dysfunction is graft biopsy. This is the gold standard, and you can review this video. Through this video, I demonstrated the recent BAMF 2017 and the diagnosis of rejection, acute and chronic. So it is nice to go ahead, and this is the videotape of antibody mediated rejection. A lot of biomarkers are already known to help in the diagnosis of the non-invasively the allograft dysfunction. And here, as you see, antibody assay, anti-HL antibody, and this is the most respected biomarker, is to measure anti-HL antibody before and after transplantation. Periodically after transplantation, searching for development of de novo donor-specific antibody. This is the best biomarker that we have in transplantation. All other biomarkers are still for research purposes. Okay? So the gold standard for diagnosis of allograft dysfunction is biopsy, histological diagnosis, and the best biomarker we have now known, and there is an agreement between the transplant physician, is to follow donor-specific antibody. And this is the key learning from this article. Antibody-mediated rejection with donor-specific antibody is currently the main cause of graft dysfunction, and this is why if the patient has preformed, this means anti-HL antibody, donor-specific, present before transplantation, preformed, or de novo, there was no, here this is the preformed, and here the de novo newly formed after transplantation. Just knowing it is preformed or de novo, this determines the type of rejection. So type 1 antibody-mediated rejection occurs in patients whom the preformed anti-HL antibodies were detected and diagnosed, and type 2 antibody-mediated rejection occurs following donor de novo DSA. Okay? Is there a difference between type 1 and type 2 antibody-mediated rejection? Yes. The two major differences is their timing, which occurs earlier. Type 1 occurs earlier, and type 2 occurs little bit later. Okay? And the second, the prognosis of type 2 is more bad, more worse than type 1. So type 1 is of better prognosis than type 2. So this is why we should follow the patients to know if they're preformed or de novo. And the presence of anti-HL antibody either before or after transplantation are associated with antibody-mediated rejection and the bad consequences. So preformed antibodies are bad. De novo antibodies are more worse even. Let us go to this very interesting study that is published in the current issue of Kidney International. Here, this is very interesting. They look at antibody-mediated rejection. Okay, so at the time of rejection, they tested the blood for the presence of donor-specific antibodies. Not only this, but also they determined if these antibodies are of complement C1q binding capabilities or not. So this is at the time of diagnosis of antibody-mediated rejection. And 3 months after treating antibody-mediated rejection with the standard treatment, IVIG, plasma, and rituximab, the biopsy is repeated, and not only this, but also C1q binding capabilities is reassessed. So DSA is monitored at the time of rejection and 3 months, and as well as the C1q binding capabilities. And based on these points, we have C1q negative at the time of antibody-mediated rejection, C1q negative after 3 months, C1q positive, then became negative, positive and persist positive, negative and changed into positive. They proved that if the C1q persists as positive or changes toward the positive, this tendency carries bad prognosis, especially if it is associated with histological criteria. Please go and read this article in details because it predicts graft survival on the long term. Another very funny is to measure this virus, torque-tinovirus, DNA, and the kinetics. What does mean by kinetic? Why do I mean by kinetics? It changed the level. So torque-tinovirus level is a reflection of the efficacy of immune suppression. So if you find it, this means that the patient is adequately suppressed. If it was high and then reduced in level, this means the immune suppression is not adequate. And here you can find if the level of the virus is reduced, here this is the level of virus, what happens? Antibody-mediated rejection increased. So antibody-mediated rejection is associated with a reduction of the level of the virus. But in the cases with no antibody-mediated rejection, the level of virus is high. So this is very funny. And here, this is one of the recent articles about the kinetics of this virus, DNA, plasma load, predict rejection in lung transplant recipients. So it is one of the biomarkers. Another interesting biomarker is calprotectin. Do you hear about calprotectin, Muhammad, before? What is it? It is a marker. It is one of the innate immunity and is secreted from renal tubules as well. Mediator. Here, the key message, I think the key message is clear here. In pre-renal acute kidney injury, the level of this biomarker is not increased. But for all causes of intrinsic, either rejection, ATN, or pyelonephritis, the level of the calprotectin is high. So this is why in this smart flow for the diagnosis of acute allograft dysfunction, here you should start with ultrasound to exclude post-renal acute kidney injury. If there is no hydronephrosis, then assess urinary calprotectin. If it is low, this means you are dealing with a case with perirenal. If it is high, do ultrasound, exclude infection, and do biopsy to diagnose other causes of intrinsic renal causes of allograft dysfunction. So this is the presumption of the value of this biomarker, but still it is investigational. And this is why you can find here could calprotectin and other markers serve as troponin of nephrologists. Still, we are not convinced by this issue like the cardiologist convinced by the use of troponin to diagnose myocardial infarction. But this is one of the biomarkers, not for rejection, but to discriminate between pre-renal and other causes of allograft dysfunction. If this is a case presented with allograft dysfunction, what's your diagnosis, Muhammad?
I see a cellular crescent.
No crescent at all. There is no crescent. This is the thrombotic microangiopathy. So it is not crescent. Where is the crescent, Muhammad? No crescent. So, and this is one of our cases, thrombotic microangiopathy. What are the causes? What are the causes of thrombotic microangiopathy?
we must exclude the presence of antibody mediated.
Yes, it may be a picture of antibody rejection, or maybe just secondary to calcium inhibitors. And this is the well-known, famous isometric vacuolization of the tubules reflecting the acute calcium. Yes. And what this, Muhammad?
I see an intimate thickening of the...
So this is bus stain, and this is silver stain, and here all these are medial hyalinosis. So this is a vessel with medial hyalinose, nodular hyalinose of the media, and this is again one of the side effects of calcium inhibitors or tacrolimus. Okay, and this is the meson showing strep fibrosis of chronic calcium inhibitor use. Is there a biomarker for diagnosis of acute calcium inhibitor nephrotoxicity? Do you know? This is one of the FACIN-1 is released from proximal tubular cells in response to calcium inhibitors and correlates well with isometric vacuolization in kidney transplanted patients. So the value of biomarkers may help in diagnosis of rejection and may predict rejection as well as other causes like calcium inhibitors that you see. And the biomarkers are so many tests are considered as biomarker, but which is convincing is the follow-up of anti-chill antibodies to predict and to diagnose development of de novo anti-chill antibodies. Some cases, if this is a case with acute allograft dysfunction, what's your diagnosis?
Acute cell rejection?
No, it's not rejection. This is belonging to Professor Helmut slides, professor of nephropathology at Harvard. So this is a renal tubule. This is a renal tubule, and this is infected cast. So this is acute pyelonephritis of the graft. You can ask me if it's acute pyelonephritis, the patient should have fever and tender graft. It's not necessarily. Sometimes the clue is just histological presence of infected cast. So the presence of infected cast in renal tubules, here the diagnosis is acute pyelonephritis of the graft. Okay, this is a patient presents with toxemia, toxic. The patient appears toxic, fever, and this is the investigation. What's this, and what is your diagnosis? You don't know. This is the CT scan, and this is a graft with air. So this is emphysematous pyelonephritis of the graft. And according to the radiology, we can diagnose emphysematous pyelonephritis into stage 1, 2, and 3. In stage 1, gas is present in collecting system. In stage 2, gas replacing less than 50% of renal parenchyma, with the minimum spread to the surrounding tissue. Sepsis rapidly controlled. But in stage 3, gas replacing more than 50% of renal parenchyma, or extensive spreading of infection in the perinephric areas, or patient with evidence of multiple organ failure. Here you'll find uncontrolled sepsis, shock, not respond to medical management. The secret of success of management of emphysematous pyelonephritis is in one word: to be vigilant and early diagnosing the presence of this catastrophe. This is the literature, 23 patients were reported in this article, and 12 cases necessitated graft nephrectomy, 7 graft percutaneous drainage, and 4 patients recovered just with the use of antibiotics. The patients who recovered, sure, they were diagnosed immediately. So we should think of acute pyelonephritis and acute emphysematous pyelonephritis whenever the infection is not cured by antibiotics. So if you have resilient cases, consider this diagnosis, and the diagnosis can be picked easily by CT scan that shows the gas within the kidney. Another case, this is a case of post-transplant hypophosphatemia, and the patient is treated with oral phosphate. And then the patient presents with acute allograft dysfunction. What is your diagnosis?
Acute
This is the black color stuffs within the renal tubules, and the red color with alizarin red. So this is vancosa stain, and this is alizarin red. So it is calcium phosphate. So it's acute phosphate nephropathy. The key message from this case: whenever you treat, you should monitor the patient well. You shouldn't be aggressive in correction of hypophosphatemia. Do you know the cause of hypophosphatemia post-transplant, Muhammad? A lot of causes, like giving fluids devoid of phosphate, using, and the most important is the persistent hyperparathyroidism with normal kidney function. This will lead to phosphate wasting and phosphaturia with hypophosphatemia, bone hungry syndrome, the use of immune suppressive drugs like calcium inhibitors increase phosphate wasting. So these are the causes of hypophosphatemia post-transplant, or even use of antacid, and these drugs may be phosphate binding as well. What this? This is oxalate, because this is polarized light. So if you find the stuffs, think of oxalosis, and if you think of oxalosis, just examining the specimen under polarized light, you'll find this characteristic shape of oxalate deposition. Okay. And what is this? This is a very recently published case report. All these are tubules. What this?
Tubulitis,
What this?
lymphocytes invading tubules.
Is lymphocyte is very big like this? And this is the nucleus of the tubule within the tubule. It's very big nucleus. And this is the nucleus of the renal tubule, and this is of the invading inflammatory cell. There's a great difference between the nucleus size. So what's this? So the diagnosis is KIN. Do you know KIN? KIN is karyomegalic interstitial nephritis in renal allograft. So this is quite rare in transplantation, and it is also rarely reported in native kidney pathology. The problem is this special entity of interstitial nephritis may be from the donor side, or maybe in the recipient, and may recur after transplantation. And the most important differential diagnosis is viral nephropathy. So this is a case. What this? It is a low power. When you find low power, and here this intense inflammation, and this is with high power. What this? Describe this pathology. What is this cell? This cell.
Plasma cell.
Excessive plasma infiltrate. And here the renal tubule with intranuclear inclusion within the nucleus of the renal tubule. And this is after SCV40 stain. So it's PK virus nephropathy. And this is a characteristic intranuclear inclusion of PK. So PK is one of the most respected differential diagnosis, and we should consider it first. So before diagnosing karyomegalic interstitial nephritis, we should stain for viruses, for PK, cytomegalovirus, and adenovirus. If everything is free, we put the possibility of this special entity in the pathology. Regarding our experience, here this is the total number of transplant cases in the center, and we are very proud that we are working under supervision of Professor Ghunaim, who is the leader of transplantation in Egypt and the Middle East, and also I'm happy to work in a unit with Professor Sobh, Professor Emre Fea, and Professor Ashraf Fouda. And this is one of the lessons that we have from our experience. Just timing of post-transplant diuresis affect graft survival in live donor renal transplants. In our cases, we are expecting immediate diuresis, and rarely to find the patients with delayed diuresis. So we categorize the patient into 4 groups. Patients with diuresis within 10 minutes, from 10 minutes to 1 hour, 1 hour to 24 hours, and after 24 hours of transplantation. And if we found that if there is delay in diuresis, we will find pathology like ATN here. If here the percentage, you can look here in immediate diuresis, the expected ATN here in 3% increase significantly with delayed diuresis, and the acute rejection as well, and the chronic rejection as well. Here I think the data is very clear toward if you find the patient with immediate diuresis, we should be happy about this. And this is the rejection episodes and how they affect the graft outcome, graft survival, 5 years and 10 years. I can find here, if there is no rejection, 10-year graft survival here is 82. That is reduced if we have multiple episodes to 47%. So this is a very interesting cause. Regarding the use of radiology for diagnosis of allograft dysfunction, this is the Doppler study of normal grafts. So this is grayscale of normal graft, and here we measure the cross-section area, and when we have follow up this patient, we can know if the graft is expanding or not, so we can follow the surface area. And here we have the pulsed Doppler, the Doppler showing the resistive index, and resistive index is calculated by an equation, S systolic velocity minus end diastolic velocity divided by systolic velocity. So this is at the end it is normal. As you see here, it is 0.66. And what this is power Doppler. Power Doppler shows a perfect perfusion of the graft up to the renal capsule. So this is a case of normal. And we have this study that shows correlation of Doppler finding with biopsy. So this is a case of ATN and rejection. So you can find here the perfusion is reduced in rejection cases. Regarding the vascular complications, we have in this up to this date, we have 19 cases of renal artery thrombosis, and 2/3 of them were salvaged, and 4 cases of renal vein thrombosis and 2 cases were salvaged. And this is one of the cases. This is the patient with reduced perfusion of the graft, and the biopsy revealed rejection. After treating rejection, the patient developed edema of lower limb, and doing radiology, we found that the edema is due to DVT. Moreover, the renal vein was thrombosed. And here, treating the patient with injection with thrombolytic therapy through the intervention radiology in our center, Professor Dialysis succeeded to resume the patency of the vein, and the patient was discharged from the hospital with well-functioning graft. And this is MRI. We have this is the study of role of diffusion weighted imaging of MRI to diagnose acute renal allograft dysfunction by Professor Abulghar. And as I mentioned, there are a lot of innovation in the MRI, and this is the percentage of problems within our cases up to date. And find the number. This is approximate from 3,000. I think the figures are accepted. And here is there any guidelines? This is from European Society of Urology. Here, this is the strength of evidence for the recommendation to deal with surgical complication. So perform a color Doppler ultrasound in cases of suspected graft artery or vein thrombosis. I'm happy by Doppler and the power Doppler study, because in the past we should do angiography or renography, and we found the problems. But it's very easy to put the probe and to see perfusion to diagnose a graft artery or venous thrombosis, and this is strong evidence. Perform a color Doppler or ultrasound to diagnose an arterial stenosis. In the event of indeterminate results of on ultrasound, consider a magnetic resonance or computed tomography angiogram, and this is a strong recommendation for diagnosis of renal allograft artery stenosis. Perform a percutaneous drainage placement as the first treatment for large and symptomatic lymphocele. How to diagnose lymphocele, Muhammad, is by diagnostic aspiration and look at serum at creatinine. If the creatinine within the collection the same like blood, this means that it's lymphocele. If it is like urine, it is urinoma. So here, if you diagnose significant lymphocele, the decision is to perform percutaneous drainage. Usually, rejection is associated with increasing lymphocele, but we consider lymphocele as a reflection of lymphatic, the play with lymphatic. So this is the cause. And we have, which immune suppression is famous of lymphocele and the lymphedema? mTOR inhibitors. Okay. Manage urine leak by double J stent and bladder catheter and or percutaneous nephrostomy tube. Perform a surgical repair in cases of failure of conservative management. Strong evidence. Manage ureteral structure less than 3 centimeter in length, either with surgical reconstruction or endoscopically percutaneous balloon dilatation or antegrade flexible ureteroscopy and holmium laser incision. Treat late structure recurrence and or structures more than 3 centimeter in length with surgical reconstruction and appropriate recipient. This is a strong recommendation. Perform shockwave lithotripsy or antegrade or retrograde ureteroscopy for a stone measuring less than 15 millimeter. This is strong. Perform a percutaneous nephrolithotomy for a stone measuring more than 2 centimeter, and this is the weak recommendation. Thrombectomy in the case of viable graft and allograft nephrectomy. In the case of a non-viable graft are the treatment option for renal artery thrombosis. And the secret of success of salvaging grafts after artery thrombosis is the early detection. So we should be vigilant in our care of our patients. Interventional radiology is the first line treatment option for transplant renal artery stenosis. However, in patients considered unsuitable for radiological angioplasty, surgical treatment may be considered. And here it is wise to look at blood pressure and the number of medications used to treat hypertension. And this is the level of evidence. As you see, the level of evidence is not very strong. Surgical repair should be undertaken when conservative management fail or massive urine leak occurs. And you can see the rest of conclusion. To sum up, if you have acute allograft dysfunction, ultrasound is mandatory. If it shows obstruction, hydronephrosis, you are dealing with the mechanical. So does the ultrasound show a mechanical hydronephrosis? Yes, refer to the urologist for dealing with obstructed case. If no, renal biopsy ordered by transplant team and performed. If it is rejection, we deal with rejection. If calcium inhibitor, we go to reduce the drug. So if it is interstitial nephritis for any etiology, we can build our management according to the pathological diagnosis. And you remember that they would like to add calprotectin, but up to this moment, we cannot say it is guideline. It's just a paper. At the end of the presentation, we should continue learning. And the most important clear message from this presentation is allograft dysfunction is not restricted to the diagnosis of rejection. We should be smart, both all the differential diagnoses, using all facilities, the laboratory, radiology, and at the end of the day, the histopathological diagnosis. Thank you for attention, and I'll be happy. This is one of the messages that I received from Dr. Saud Mohammed from Eritrea. He is very happy by the videos that we upload to the YouTube, and I'm happy to receive this letter from him, and I hope that these videos help you, and thank you very much.